Topic today is challenges in treating. Our topic today is challenges in treating Candida infections in patients with comorbidities. And let me have the pleasure of introducing today's experts. Our first expert is Dr. Sanjeev Sasidharan, and he is HOD of Critical Care department in SL Raheja Hospital, which is a Fortis Group hospital in Mumbai. Dr. Sanjith has been an expert in critical care since 2019 and has been associated with well-known institutes like Hebrew University Teaching Hospital in Jerusalem, Israel, apart from Hiranandani and Seven Hills Hospital in Mumbai. He is an academician to the core with special interest in teaching, and his current role, he is also heading the hospital's Infection Control Committee and Antibiotic Stewardship Committee. He has more than 30 research and publications to his credit, also has received more than 20 prestigious awards. Just to name a few, I will run out of space in case I wanted to mention all his credentials. We also have our second expert, that is Dr. Tannu Singhal, who is a consultant in consultant pediatrics, and particularly she is, taking care of the pediatric infectious diseases at Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute in Mumbai. He's an expert in pediatric infectious diseases. He's an expert since 2008 and has been associated with prestigious institutes like Hinduja Hospital and AIIMS. Has 56 publications in reputed index journals. Has to her credit 19 poster presentation and abstracts in prestigious institutes. Has 22 books and book chapter publications to her credit, and the list is endless. Has been part of 9 reputed research projects and has been a recipient of 20 prestigious awards in her academic as well as professional career. So I wholeheartedly welcome not only the audience as well as our experts. And now, without much ado, I hand the session over to Dr. Sanjith to take us through his presentation and enlighten us. Thank you. Over to you, Dr. Sanjith.
Unmute. All right. So, good evening to one and all, and good evening, Dr. Tannu. How are you?
Yeah, I'm fine.
Yeah, well, it's nice to be there on a Saturday evening and talk a little bit about fungus, and it's a topic quite close to the heart of an intensive care doctor, because that's one thing that causes a lot of problems to a large proportion of patients, increasing the mortality in these cases, and that's why it becomes very interesting for us in this domain. What are we going to do today is we're going to look at invasive candidiasis in the ICU, and we look at a little bit of my data, how we can diagnose it, important general points in the management that I feel, and importantly, some salient features. I have a disclosure: I'm not an ID specialist, I'm not a microbiologist, I'm only a bedside clinician. So I think the other expert in the panel would probably add a lot to whatever I'm saying. Well, today I'll start the entire session and set the ball rolling by telling you a story. And I think the purpose of a storyteller is not to tell you how to think, but to give you questions to think upon. So I guess by the end of my presentation, we will probably have a lot of questions that we will have in our mind, and I hope we can answer a few of them with the help of the expert panel that we have today. Well, this is a 65-year-old male patient, diabetic, hypertensive, asthmatic, on a regular nebulized steroids and bronchodilators. And the last admission for an acute exacerbation was 2 years ago. It's fairly controlled asthma. He never went out of the house, and this is the usual story. Day 1, he was not okay, and day 4, the RT-PCR comes out to be positive. So this is a patient who got COVID. He is kept at home till day 6, home quarantine. Day 7, he reaches the hospital coughing. This is what really occurs to this patient. So he reaches the hospital on day 7. We give him 6 milligrams of dexamethasone, high dose vitamin C, a high dose ulinastatin, a helmet CPAP. And then what we find is that on investigation, he had respiratory compromise. PF ratios were less than 150, actually going in favor of ARDS. Plus, He had interleukin-6, CRP levels, ferritin, D-dimer, all above in the inflammatory range, and the neutrophil lymphocyte ratio was 16. The LDH was also high, and when we did a clotting index, I mean a thromboelastography, we found the clotting index to be quite high, indicating that he had everything that we know about COVID as of now. He received tocilizumab at that particular day, and before we did find that the breathing got better, the saturation started kind of getting better, the CRP also came down, ferritins were better, neutrophil lymphocyte ratios were better, LDH was better, but the BP was kind of borderline. It's not really really the way it was. He came at 120 odd, and he was at 100 systolic on day 4 post-TOSI, the first day post-TOSI, that is, I mean day 4 post-TOSI, that is. So he also had a vague abdominal pain. On day 5, we did an amylase lipase, we didn't find anything there on that. And on day 5 post-tocilizumab, there was a drop in the blood pressure. A very, very tiny dose of vasopressor was added, a very tiny dose. But the WBC counts just shot up to 26,000. Ferritins went up, LDHs went up. So at that phase, when we saw all these things, we decided to, we thought maybe it's the tocilizumab, maybe it was so we sent a blood cultures, and we immediately added this patient on meropenem, teicoplanin, fluconazole. This patient wasn't on any antibiotics when the patient came in. And so but we still started this patient on meropenem, teicoplanin, and fluconazole. And day 6, the very next day, there was a drop in the blood pressure and a higher dose of vasopressor was required. A repeat WBC count showed that the WBC shot up to 36,000. The creatinine also now started changing. This is in spite of doing quite a good management on the fluid management. And lactates was 26, procalcitons were 2.9. We changed this. We changed this meropenem with this fluconazole to echinocandin. This is what we did. So we had a fair usual story that we see we saw quite a bit in the second wave of COVID, with a patient with comorbidities who received anti-inflammatory therapy and subsequently went into shock. And day 4, day 5, day 6 post tocilizumab were the defining days, where day 4, though the breathing got better, there was a BP that was borderline. On day 5, after the tocilizumab, there was the WBC concept went up, and there was a small dose of vasopressor added. And on day 6, the vasopressor dose needed to be escalated. So we sent a blood culture 2 days, around 4-5 days. We have this tendency in our hospital to send blood cultures on every 4th day that the patient has been in the ICU for COVID. And what we found out was that the patient had Candida auris with Enterococcus faecium in the blood culture from the peripheral side. Patient was intubated, ventilated for severe acidosis subsequently. Huge respiratory distress, but died quite early, day 9 of intubation with multisystem organ failure. So this patient, I felt, had a lot of questions in my mind. I mean, where was the source of this fungus? Was it the line? Was it primary fungemia? So let's go to each of these one by one and my take on these particular questions. So first, the incidence of Candidemia in India is at least 20 to 30 times that in the developed world. And in India, at least 43% of all Candidemia patients may have a very fatal outcome. What's predominantly seen? Well, this is the study that we normally quote when we talk about prevalence, and this is Arunalok Chakraborty study that was done, study in 2014, which is actually representative of 3 years before that. And I think it still holds the same significance. Around 41.6% of most of the prevalent pathogens were Candida tropicalis, followed by and this was the prevalent Candida, and the approximate rate is somewhere around 7% in this study. And of course, they found that the public sector had more kind of Candida as compared to the private sector, and the resistance pattern they found was 1.9% in these patients. Well, what's my incidence of Candidemia? It's around 5 to 6% in all the samples that we see in the hospital. And most of these usually come from neutropenic, and whenever they come, they usually die. When they get candidemic is what it looks like. 2 out of 3 died, and among the non-neutropenic, 50% did die, and most of them, common to them was long stay and the use of TPN. What's the commonest? It is Candida tropicalis in my ICU, and when we actually published this study also. When we looked at all the isolates, we found non-albicans Candida species to be predominant in the blood, very similar to the studies that were done in the past. And these were just sample by distribution of all Candida isolates that we had. And when it was very clearly Candida albicans was 49, but the rest of the organisms showed a large number. And then we published this particular data that looked at colonization of central lines only. This was a while later that we did. And in 2021, this publication has come out around 4-6 months ago. So this was one publication where there was, I don't see a Candida auris at all. And in this publication, we see a small amount of Candida auris that comes in very clearly. And it's important, the study, why am I putting up the studies? Because it gives me something very, very different from what we've learned. Here, it didn't depend on the duration of the central line. When we think about the concept that colonization will then become kind of infective, it doesn't show that more the days of the central line, more of the colonization. It doesn't show that there is no relationship is what it looks like. And for some reason, it also showed, my study also showed that it doesn't really depend on the antibiotic days also. What's important in this is that in the 2007 publication of ours, we didn't have a single Candida auris. And then we went to 2021, we had multiple Candida auris detected in many of our samples. So let's go back to our case and see what went wrong when we actually looked at particularly was this bacterial sepsis. On day 6, there was a drop in blood pressure. Vasopress was added, WBC was 36,000. We did add meropenem, teicoplanin. Could this have been bacterial sepsis and not just fungal sepsis? Could this have, so is there a way to differentiate between really bacterial sepsis and fungal sepsis? Well, I feel they look very, very similar to each other, but I think there are 3 very important differences that we may help to guide us in this particular diagnosis. And out of that, I think there are 3 things: the severity and the lactates and the procalcitonins that might help us differentiate bacterial sepsis from fungal sepsis. Well, this is a study that was done by Susan Hadley from the Norocept 2 database of patients who were treated with whom they studied retrospectively. And what they found was, in those non-immunocompromised patients, the ones that were candidemic septic shock had sustained multiple organ failure and showed actually delayed recovery from organ failure, is what it looked like. Well, mortality rate was also higher as compared to bacteremic septic shock. And more importantly, the lactates were lower as compared to bacterial sepsis. So the study done 20 years ago, I mean, I would say 20 years ago, would actually differentiate bacterial sepsis from fungal sepsis by looking at the mortality, the lactates, and the severity of the illness, definitely indicating that the fungal infections are kind of more severe. And if you looked at this entire database, they found out that when the source was the abdomen, the mortality seems to be higher. Well, the other reason why we could probably look at and differentiate between bacterial and fungal is the use of procalcitonin. And this beautiful study done by Andrea Cortegiani from the Barnes Jewish General Hospital, they looked at a large number of retrospective databases from their initial hospital information systems and found out that the lower the procalcitonins was seen usually in fungal infections to the tune that it was around 0.99 nanogram per ml, versus bacterial sepsis where the bacteremia had somewhere around 16.75 nanogram per ml of procalcitonin. Definitely a big change between fungal sepsis and bacterial sepsis here, with the area under the receive operating curve being very good for, if you look at the negative predictive value, 96.3 was a negative predictive value when you actually looked at the cutoff of 6.08 with procalcitonin. What does it look like? So it means to say that we may be able to actually rule in or give us some kind of guidance when we actually send off procalcitonin when you look at fungemia versus candidemia versus bacteremia. Did we miss out on the diagnosis here? I mean, in any way, could we have diagnosed this early, this Candida auris? Could we have diagnosed this early, this before we got into this mess? Well, the entire problem lies with the fact that this is the basic problem with fungal sepsis. Blood culture takes a very, very, very long period of time. By the time the blood culture comes in, we've kind of missed the bus, is what it looks like. And that's the reason that we tend to use non-culture based tests. There are a large number of them in the market: serum galactomannan, mannan, antimannan, SACTA, T2MR, but the ones that we use regularly and what is available freely is the beta-D-glucan. And this, probably being a pan-fungal marker, is one of the markers that might help us to actually figure out whether there is candidemia or not. When we look at it, we must be very careful in interpreting the results of beta D glucan, because many other things might cause false positivity, and that's why we look at 2 beta D glucans. In fact, the beta D glucan also has a very good negative predictive value when we're actually looking at Candidemia. So this is a pan-fungal marker that we use. And am I using scores? Well, there are multiple scores that are used to diagnose invasive candidiasis, and Candida prediction rules like the Lyon score, you have the Ostrowski-Zeichner score. If you look at most of them actually says the same thing. They all say that you may have surgery, you may have multifocal colonization, you may have TPN, and you may have severe sepsis. And when the score becomes more than 3 here, this Candida score would actually go on to say that there is a high incidence of getting invasive candidiasis. In this aspect, it's this Candida colonization index, which has been in the place for the last more than 20 years, gives us a fair bit of an advanced idea of whether this patient can get infection. In fact, this is one of the few things that has helped us to understand the association between colonization, then going on to get infection. This is one of these concepts that was actually shown by the Candida colonization index, where if the colonization was there in a big amount versus the ones that you were actually screening, and the figure was more than 2.5, we could actually call this that this is one of those cases that might go into invasive candidiasis and might help with empirical management, empirical or preemptive therapy. Well, this scores on its own, if you use it on its own, the positive predictive values are extremely low and will not help you to actually diagnose the fact that there is candidiasis. In fact, these were actually in place to identify patients with increased risk of invasive candidiasis, but the positive predictive value was extremely dismal, and in fact it had great negative predictive values what it looked like. So what do we do then if that's the case? If these markers are not good, if these this kind of scores are not very good and the cultures are not very good, so we have to use these all together. So as this colonization index ideally was actually made and studied and validated in a group of surgical patients. So in a surgical patient, it definitely works very well, is what it appears. I mean, if the colonization index is high or the Candida score is more than 3, and you add in predictive model, the biomarkers and your clinical gestalt, maybe with this we'd probably be able to diagnose fungal infection. So my entire thing on diagnosis would be based on the combination of a predictive model, a biomarker, and definitely a clinical gestalt. So that's what I would probably do if I were to diagnose this. So what happened in this case? Did we delay giving? So this patient had all the scores right. Did we delay giving appropriate antifungal? So if you look at this, day 4, there was borderline blood pressure. Clinically was not okay. That is the time that I actually put the patient on fluconazole. Day 5, vasopressors were added. Almost 24 hours later, vasopressors were added, and we actually escalated to an Echinocandins, what it was as per the case. Did we make a mistake? Well, it does look, at least from this very famous Morel study done way back in 2005, where they actually looked at what would happen if you delay giving an antifungal therapy. What's very clear in this is that the percentage hospital mortality seems to go up extremely high if you were to delay it beyond 12 hours. In fact, another study came out right after that from Italy, from Santa Maria, that is Matteo Bassetti, also looked at this retrospective cohort study, where what they found was if you actually gave adequate therapy and adequate source control within, say, 12 hours, the survivability was much, much higher than if you gave it later on after 24 hours. So after 24 hours, the survivability was not very good, and it was extremely worse if you did not do source control, is what it looked like. So did we really delay source control? Well, here we had a central line a while ago, before all this time. And I think that's the source, because when we actually looked at that, the central line we found, and surprisingly, we never had fungal culture before COVID. And it's after COVID that we started getting these fungus and all growing here and there. So if we delay source control, well, it does look like that, because what's important is there's another study that actually went on to say the same thing, that if you give an adequate antifungal, these patients didn't do as well as if you did septic shock, as well as if you did a combination of source control as well as adequate antifungal therapy. So it's not adequate enough just to give an adequate antifungal. We need an appropriate source control ASAP in order to achieve better outcomes. Well, what's my stock drug usually? Usually my stock drug was initially fluconazole, but since the time, if the patient is even slightly or severely ill or in the ICU, then it definitely is Echinocandin, especially because it's idle and rapidly active. And more so when Marin Kolev put up this important study that actually looked at, from the University of Manitoba, they looked at this study that actually said if the initial antifungal agent was Echinocandin in Candidemia, then the almost 76.8% of them lived as compared to 49% who died. So it goes on to say that Echinocandin seems to be the way to go if the patient is severely ill. And this comparison between Anidula fungin versus fluconazole for invasive candidiasis also, though it has got its own set of limitations, this particular study also went on to say that Echinocandins make a big difference in care. If you look at the same study, very low down there, the death not due to Candidemia or invasive candidiasis and Anidula fungin was 10 and fluconazole was 16. And the only thing that was important was the receipt of this particular dose Echinocandin that actually helped to reduce the mortality in that group of patients. Well, when we characterized our specimens, we also found the same thing, that Echinocandins were kind of sensitive to almost most of the organisms, most of the Candida species that were grown in our hospital. The next question that comes up is, if this line was kind of colonized, would I have changed the line over a guide wire, retained the precious line till cultures? I would never do that, especially because we know in this from this study, a very, very important study that said that if you removed the center line, the mortality was much lower than if you retained the center line. So so it's nowadays become very simple to put center lines, and we really don't have to think too much. The ultrasound guided center lines have become very simple, and so very easily, very importantly, the message should be there that if the center line is the source of infection, that should just fly out, because it's extremely dangerous to have a center line in place, and that is the source of infection, especially when it's a fungus. Well, there are 4 types: prophylaxis, empiric, preemptive, and specific. And if there is repeated positivity on appropriate antifungal therapy, look at the eye, back, lung, brain, and then look at my pharmacokinetics and pharmacodynamics, whether I'm doing the right thing over here. Do I treat the candiduria? Unless there is urological intervention, liver transplant, or preterm low birth weight babies, I don't think there's any role of treating any candiduria. This is what happened to our blood cultures. We saw Candida auris, and within 2-3 days time, we found multiple patients having Candida auris. This is in a span of within 7 or 10 days. We got many Candida auris here and there, and we had a very, very tough time at this time to get this out. That's why this particular organism, I think, probably was less diagnosed in the past. I think all the Hebellunae and all the Gullaimondi that we saw was probably Candida auris, and we mistook it for those particular organisms, is what I feel. So the prevalence of this particular organism, which is an MDR, is definitely going up, is what it looks like for certain. And majority of these cases reported from critically ill patients. Environment seems to be the source. Biofilm formation is very resilient. Biofilm formation is formed, and they can be asymptomatically colonized for a long period of time. Well, 2009 we had 1 case. In 2019, I just happened to look at the literature from 560 cases that have already been reported in the Candida literature. And this particular organism will be and going to be one of the biggest menaces, and that's why it's a global challenge for Candida auris. Especially, it's created a worldwide alert. The antifungal resistance is too high. It's a very resilient organism, and it doesn't go off from by usual disinfection methods of quaternary ammonium compounds. It's got a high infectious potential, and it survives for a long period of time, and it's resistant to most of the antifungal agents. Well, we started with the case analysis. We looked at infections. We looked at the nuances of diagnosis, the problems faced. We gathered some knowledge here and there. I feel the key to effective management is the quick clinical pickup, the effective use of serology, the rapid institution of source control and antifungals, and an appropriate use of drugs. Thank you very much. And these PowerPoint presentations are available on my website, free for anyone to see or hear. Thank you very much, and I hand over the the session to Amitabh back. Thank you. Thank you very much.
Yeah, thank you very much, Dr. Sanjith. And it was really an enlightening session. A few questions have propped up. I'm sure that few more will prop up. And let me assure you that most of the audience that we have are from critical care setup. And you will see, going by my past experience, very insightful questions going forward. Some questions have come, which we will take at the very end. Let me assure the audience. My request to all of you that you will not be able to ask the questions through the voice, but you can type in your questions and they will surely be answered by our expert. Over to you, Dr. Tannu Singhan, for your session and your take on the cases of Candida infections in patients with comorbidities.
Good evening, everybody. Can you hear me?
Yes, ma'am.
Yeah. So I think I'm going to take on from where Dr. Sanjeev left, because he talked about invasive candidiasis. And I'm going to really talk about the echinocandins in my presentation and how are they similar and different. So this is in a snapshot, the current guidelines about treatment of invasive candidiasis. So these are the IDSA guidelines which were published in 2016. And this is just, the kind of setting and what is the preferred therapy. So if you look at empiric therapy in non-neutropenic ICU patients, the echinocandins are preferred. And fluconazole can be used as an alternative only in those patients who are infected with azole-resistant Candida or who have no previous azole exposure. Now, if you look at Dr. Sanjeev's case, the case was in an ICU which had a prevalence of other Candida which were not azole sensitive. So maybe in such a situation, your choice of empiric therapy should be an echinocandin rather than fluconazole. And if you grow an azole sensitive Candida, then you can probably de-escalate. Liposomal amphotericin B is no longer really a drug of choice because it has its associated side effects. So it's mainly given to those people who are either intolerant or who are resistant to the echinocandins and azoles. Now, if you look at candidemia in ICU patients, that means demonstrated candidemia. That means once you know that the person is infected by cultures, again, the therapy which is preferred is echinocandins. In fact, fluconazole is only recommended in those who have azole susceptible species and who are not sick. So that means even if you grow a Candida tropicalis or a Candida albicans, which is fluconazole sensitive, the dictum is to use the echinocandins up front and then de-escalate to fluconazole once the patient is better after 3 to 4 days. Now, neonatal candidiasis, with which I deal with commonly, is quite different because in neonatal candidiasis, actually amphotericin B deoxycholate is the drug of choice because in neonates, you have a lot of involvement of the CNS and the urinary system. And therefore, you don't use fluconazole initially and you don't use echinocandins because we know that echinocandins don't go into the brain and urine too much. When we look at CNS candidiasis, again, it is treatment sans the echinocandins, where you use the preferred therapies liposomal amphotericin B with flucytosine, and alternative treatment is fluconazole, which is usually used as a step-down therapy. If you look at endocarditis, then the earlier treatment was with combination of liposomal ampho B and flucytosine, irrespective of the azole sensitivity of the isolate. And now high-dose echinocandins means using either Caspo in a dose of 100, Mica in a dose of 150, or Anidula in a dose of 200 is also recommended. And fluconazole is used as step-down therapy. Bone and joint infections, fluconazole is the drug of choice because these patients are not very sick and you need to give protracted therapy. Urinary tract candidiasis, again, fluconazole is the drug of choice because it achieves excellent levels in the urine. And but nowadays we see a lot of UTIs because of azole-resistant Candida, and I'll be presenting one such case. And in these patients, you may have to use amphotericin B deoxycholate or flucytosine. And then finally, for oral and esophageal candidiasis, again, the preferred therapies, fluconazole, and other drugs can be used if it is resistant to fluconazole. So you can actually see that depending on the type of candidiasis, you have choice of various agents. And so today we'll be mainly talking about the ICU patient who are very sick and where echinocandins are preferred therapy. Now, echinocandins, they are more similar than different, and I'm going to highlight some of the important properties of these drugs. So these are all semi-synthetic lipopeptides that act by inhibiting beta-D-glucan synthesis. They are all approved for invasive candidiasis, and they are fungicidal for Candida. But remember that there are two Candida species, that is Candida parapsilosis and Candida lusitani, which have high MICs. And therefore, in these infections with these agents, you may want to use azoles. The other important point is that they all have few adverse effects and drug interactions. So unlike Ampho-B, which has a lot of adverse effects, and unlike azoles, which have a lot of drug interactions, these drugs are pretty safe. They are all available only through the IV route. They all have to be given only once daily because they are highly protein bound and they have a long elimination half-life. So they can be given once a day, and therefore they are suitable for outpatient therapy as well. None of them penetrate the CNS, eye, and urine, although there are subtle differences, and we'll come to that later. And all these patients have the echinocandins, they are degraded or metabolized by the liver, and the renal excretion is minimal, and therefore none of them need any kind of renal dose modification, and they are not cleared by dialysis. So you don't need to give a supplemental dose after dialysis, which you have to give for many agents. Now, all have concentration dependent activity. So that means the pharmacodynamic parameter, which is used in these, is the Cmax over MIC. Then, as far as Aspergillus is concerned, they're all fungistatic for Aspergillus. So we must remember that, there are a lot of drugs of choice for Aspergillus, and you only use them where you can't use the azoles, or you can't use amphotericin B, or you use it for salvage therapy or sometimes with combination therapy. They have some activity against pneumocystis, and therefore sometimes these drugs can be used in severe pneumocystis pneumonia where you can't use cotrimoxazole. And importantly, that they do not work against mucorals, Streptococcus, Fusarium, Scedosporium, and Trichosporon. So that means when your lab tells you that your blood culture is growing yeast, you have to be careful. Though you can start Echinocandins, but you should start identification of the yeast very quickly, if possible by MALDI, because if you're having Trichosporon or some other yeast in the blood, or maybe Fusarium, which also sometimes looks like a yeast in the blood, your Echinocandins are not going to work. Now, moving from the similarities to the differences, and that I think is the important thing, which helps us decide how we are going to choose between these drugs. Now, if you look at the approval, Caspo was the first drug to be approved, followed by Mica Fungin and followed by Anidula Fungin. That means these drugs are at least a couple of decades old. Now, those all of us know, so I'm not going to repeat that. And this is important. So stability after reconstitution is only 24 hours for Caspo and Anidula Fungin, whereas it is 48 hours for Mica Fungin. And this is something which is especially useful to pediatricians, because in our children, we use lower doses. So we can preserve a vial and use it for up to 3 times. And that actually helps because the drugs are very expensive. Now, if you look at the volume of distribution, you find that the volume of distribution of Anidula Fungin is actually the highest as compared to Caspo and Mica. Now, this should not be considered as an advantage for Anidula Fungin, because when we are talking about Candidemia, we want the drug to remain in circulation for a long time. However, there is no evidence to show that this different volume of distribution of these 3 drugs is anyway impacting their efficacy. Again, if you look at the elimination half-life, you find that Anidula Fungin has the longest half-life. Route of metabolism is basically, for Caspo, it is spontaneous degradation of the molecule and metabolism by the liver. Mica Fungin is only metabolism, and Anidula Fungin is only degradation. And that is important because then you know that if there is any hepatic dysfunction, you are not going to it is not going to affect the Anidula Fungin, and its interaction with other drugs is going to be low because it does not depend on the hepatic metabolism system. Now, percentage excreted unchanged in the urine is very less for Caspo. It is higher for Mica Fungin, and that is one advantage of Mica Fungin in management of urinary tract infections. And we don't know what is the excretion of Anidula Fungin in the urine. Another important difference between the three echinocandins is that for caspofungin, there has been described a paradoxical decrease in antifungal activity due to shift from glucan to chitin synthesis if excess amount of caspofungin is given. So if you give higher doses, you may actually cause a decline in the function by shifting from the glucan to the chitin synthesis. But the practical importance of this phenomena is not known. Maybe in a patient with moderate hepatic disease, if you're not lowering the dose of caspofungin as is recommended, you might land up with problems. So that is something which you need to remember. Now, as far as the adverse effects are concerned, caspo may cause mild increase in liver enzymes, which is not significant. Mica fungin has been associated with the development of liver tumors in rats, and therefore it comes with a warning here. Whereas with Enedula fungin, you don't really see any adverse effects. Drug interactions are important. So if you see with caspo, you have a lot of drug interactions because there are various drugs like rifampicin, nevirapine, efavirenz, phenytoin, carbamazepine, dexamethasone. They decrease the caspo levels. Caspo decreases the AUC of tacrolimus by 20%. So if you're giving caspofungin along with TAC, you have to monitor the TAC levels. But there are reports of synergistic activity between caspofungin and tacrolimus for treatment of fungal infections. Mica fungin has some drug interactions because it increases the levels of sirolimus, nifedipine, and itraconazole, whereas Enedula fungin does not have any drug interaction. So that means if you have a patient who is on any of these drugs which I've mentioned, you may want to use Enedula fungin. Now, dose adjustment in hepatic dysfunction. So in mild hepatic dysfunction, caspo, no dose modification is recommended. In moderate disease, the dose should be reduced to 35 milligrams per day. But for mica and Enedula fungin, no dose adjustment is needed. As far as use in patients with hepatic dysfunction is concerned, for both caspo and mica, because they have not been studied well in patients who have severe hepatic dysfunction, the use of these two agents is not recommended in severe hepatic dysfunction. And as far as pediatric approval is concerned, both caspo and mica fungin have been approved in children, and the maximum data is with mica fungin, and Enedula fungin, though not approved, is now the subject of various studies because now we have started seeing even resistant fungi in pediatric population, where obviously you can't use azoles and you may not be able to use amphotericin B, and therefore you have to use echinocandins. So, data about the use of echinocandins in children is also increasing. Now, therefore, there is really not much to choose between the various echinocandins. You have to decide based on the cost, availability, and logistics. And in some patients, one can tailor therapy for a specific indication. So, and I'm going to discuss 3 such cases where we used each of these echinocandins because of the situation of the patient. So let me come to the first case. This is a 53-year-old with diabetes mellitus and ischemic heart disease. He had left ureteric colic, and of course the CT was done, which showed that he had hydronephrosis, and there was a calculus. So he was admitted, and because he was in intense pain and there was hydrocephalus, it was planned to remove the stone. He had no fever at that time. His white cell count was 13,000 though, and his urine, which was sent at the time of admission, was sterile. So he underwent left ureteroscopy and stone removal with a placement of the DJ stent. And as is the protocol in our hospital, when they actually do any kind of urologic intervention, they use a BL-BLI combination because of the high prevalence of ESBL E. coli. So this patient was given cefoperazone sulbactam in hospital and then oral cefexime clavulanic acid for 5 days at the time of discharge. But 4 days after the discharge, the patient presents with high fever with chills. And because you've just had a patient undergo a urologic intervention and now it's coming with high fever and chills, you obviously suspect a urinary tract infection. So this patient's count was high. His CRP was very high. Creatinine was mildly elevated. The urine showed 10 to 12 pus cells and yeast. A CT was done. And if you look at the left kidney, there was some perinephric fat stranding, which was seen here. And therefore, the patient was started on IV meropenem, but after 48 hours, the culture came back as Candida glabrata, and it was sensitive it was resistant to fluconazole, it was sensitive to vori, flucytosine, ampho-B and mica fungin, but resistant to caspofungin. So sometimes you can have differential sensitivity to the echinocandins also. Anisula fungin is not reflected here because Vitek does not give sensitivity for anisula fungin, and you have to put a separate E-strip. So now the fever persists despite 48 hours of meropenem. A repeat culture was sent, which also shows Candida glabrata, because earlier the thought was that what if this is a colonizer, because this patient has been on antibiotics and he had a urinary catheter for a day after the ureteroscopy. But the second urine, which was sent the next day, also grew Candida glabrata, and the BDG was positive. So now we were fairly certain that we were dealing with a case of Candida urosepsis, possibly hospital acquired. So now what are you going to use? So as far as voriconazole, the organism was sensitive to voriconazole, but it is not the preferred therapy in Candida glabrata, unlike Candida cruzi, where you can use voriconazole and it does not penetrate the urinary system. 5-flucytosine has good urinary penetration, but it cannot be used alone because the Candida grows resistant very quickly. So you have to use it always in a combination. Amphotericin B, you can't use liposomal amphotericin B because liposomal amphotericin B spares the kidney. And you can use amphotericin B deoxycholate, but there is a concern about nephrotoxicity. This patient already had hydronephrosis, he had a lightly elevated creatinine, he has diabetes mellitus, and he also has pyelonephritis. So there is a concern about using a nephrotoxic drug here. So what about mica fungin? But again, we are led to believe that, the echinocandins don't penetrate urine very well. So that is a downside. So if we reviewed a little bit, and we found that there was some discussion in literature about, mica fungin treatment and eradication of candiduria amongst hospitalized patients. So this was a retrospective study in which they had about 33 patients, and they had to use mica fungin for maybe because of resistance, etc. And they found that sterilization was achieved with mica fungin to the tune of 81, 78, and 75% respectively. So they were able to eradicate the fungus. Similarly, there was another study in which they had 6 patients who had UTI, and in 4 of them it was due to a fluconazole resistant candida, and in 2 basically these patients had hepatic dysfunction and they had fluconazole sensitive candida, and we know that fluconazole is also hepatotoxic. So these patients were treated with mica fungin. And similarly, there was another case report of a patient who had a resistant Candida glabrata urosepsis, which was treated by mica fungin. So therefore, in this patient, because we could not use any of these drugs, we started IV mica fungin, and we know that whenever we have a Candida infection, you have to remove the foreign body because it forms a biofilm. We removed the stent, the fever got better, the repeat urine culture was sterile, and the DJ stent was also negative for fungus. We gave IV mica fungin for 14 days and the patient did well. Of course, we need to do an infection control investigation as to how this patient landed up with the Candida glabrata infection post, ureteroscopy and DJ stenting. So we have seen several cases of fluconazole resistant Candida UTI. Of course, when you grow Candida in the urine in a patient, you have to be really sure that it is a pathogen and not a colonizer, because most of your patients in your ICU who have been on antibiotics or who are diabetic or who have a catheter will grow Candida. But let us say you have ruled it out as a colonizer and you know it is responsible. Like in this patient, we were certain that Candida was the cause of urosepsis. You are faced with the predicament of treating them because you're seeing more Candida glabrata, Candida auris in the urine. Now, if the patient has a mild infection, you can try fluconazole, because even though the Candida may be in vitro resistant to fluconazole, because fluconazole concentrates in the urine, you may achieve success. But in other situations, you will need other drugs, especially if the patient is as sick as this patient who had high fever, who had a CRP of 217. You have to use other drugs. So our institutional protocol is mica fungin in patients with azole-resistant Candida UTI as choice amongst the Echinocandins, and also remember that patients who are colonized with azole-resistant Candida, if they have to undergo a urological intervention, you have to give them peri-op Mica Fungi, because otherwise it will lead to what is called as Candidemia arising from a urinary tract source. So that is why all patients who undergo urological intervention should have a pre-intervention urine culture. And if you show Candida there, then you have to use treatment for that as prophylaxis. Otherwise, you may land up with Candidemia. Now, the only one thing which I would say is that other Echinocandins have really not been evaluated in management of urinary tract infections, and they may also work because these Echinocandins achieve good levels in the urinary, in the kidney. And similarly, there are case reports where voriconazole also has been effective in treatment of UTI simply because it achieves excellent levels in the renal parenchyma. So, we have to kind of accumulate knowledge about these other drugs. So this was one case of where we specifically used one echinocandin in preference of the others. Now, let me come to the next case. This is a 58-year-old patient who had hepatocellular carcinoma, and he underwent, after he finished his chemo and all, he had to undergo resection, and he underwent a living-related donor liver transplant on just recently, about 2 to 3 weeks ago. And as is the protocol in our hospital, peri-op prophylaxis was given with piperacillin tazobactam, and the surgery was prolonged. It went on for about 8 hours, and fluconazole prophylaxis was started post-surgery, as is the protocol in our hospital. So the patient was intubated and mechanically ventilated till day 5 because the surgery was prolonged. And unlike most patients who get extubated on the next day, day 5 he had fever and fall in blood pressure. So blood cultures and BDG was sent, and at the same time his bilirubin went up and he had rising liver enzymes as well. So because we suspected severe sepsis and this was a highly compromised patient, we started him on regime for carbapenem-resistant gram-negative bacillus and also started IV Anidula Fungi. Now, this new onset sepsis in a liver transplant recipient, the commonest cause in our ICU is carbapenem-resistant GNB, mostly Klebsiella pneumoniae. And we also see fungal sepsis, and the risk of fungal sepsis is high in the following situations. If the surgery is prolonged, if multiple blood transfusions are given, if re-exploration is done, or if the patient had fulminant hepatic failure for which transplant is done, if there is rejection, or if the patient is on dialysis. So if you look at this patient, he had basically at risk for carbapenem-resistant GNB, and he also had higher risk of fungal sepsis because the surgery was quite prolonged. And for antifungals, we chose Anidula Fungi as it can be used in severe liver dysfunction, because this patient's bilirubin was 8 and the liver enzymes were quite high because of the portal vein thrombosis. The patient improved, the blood cultures were negative, the CT abdomen was normal, so that didn't look like a bacterial cause. The BDG came very high, hence Anidula Fungi was continued and source control was done. But unfortunately, the patient succumbed later not because of sepsis, but because of other problems related to blood supply and portal vein thrombosis. So this is one case, where basically which illustrates many things. The first thing is that when you have sepsis in the ICU, you have to think of fungus along with bacteria. And once you have thought of fungus, you must send serology and you must start an appropriate antifungal here, because one is this patient was already on fluconazole prophylaxis. So obviously you had to go higher. And also if the patient was sick with hypotension, you would obviously choose an echinocandin. And then coming to the last case. So the last case is that of a 56-year-old male with multiple comorbidities. He had come to us from Indore. He had a hemorrhagic stroke and then needed EVD. He developed bacterial meningitis and ventriculitis, which was treated, had hydrocephalus. So we had placed a VP shunt for him, and the CSF at that time was sterile. Post VP shunt, after some time, he developed fever and drop in sensorium, and a shunt tap was done, which showed that there were cells with predominant polys, low sugar, and the gram stain showed budding yeast. So once we got this report, we started the patient on liposomal ampho B and flucytosine, as is the protocol for CNS Candidiasis, and the shunt was removed and an EVD was placed. And then we got Candida auris. And the shunt, proximal and distal end also grew the same fungus. So liposomal amphotericin B was stopped and caspofungin was started because the sensitivity report which we got showed that the isolate was sensitive to flucytosine, caspofungin, and voriconazole, and it was resistant to amphotericin B. Now, the EVD, however, the CSF was repeatedly positive for Candida auris. And the main problem with our regime right now was that the caspo was not going into the brain, and flucytosine alone may not have not been enough. So we also thought about using voriconazole, but the susceptibility was by Vitek, and there are no established breakpoints for voriconazole for Candida auris. And if the isolate is resistant to fluconazole, we are not sure that voriconazole will work. So we didn't know what to do. And we came across this paper by Dr. Soman, and where they talked about use of caspofungin in a patient who had a resistant Candida albicans meningitis, intraventricular caspofungin. So what we did was that because the patient's infection was not clearing with the current regime, we initiated intraventricular caspofungin 10 mg through the EVD, and we started voriconazole in higher than usual doses and continued systemic flucytosine and also systemic caspofungin. Now, this is the pattern. So if you look at day 0, which is the day where the patient had the shunt tap done and the gram stain had shown fungus when he was on amphotericin B and flucytosine, then switched to caspo and flucytosine until day 7. With this systemic regime, the CSF was continuously positive. But on day 10, when we added voriconazole and intraventricular caspofungin, the CSF became negative. So flucytosine had to be stopped because of toxicity, and that's one big problem with flucytosine. And then we stopped the intrathecal caspofungin after 10 days and continued voriconazole. And when the CSF remained negative after stopping caspo, we reinserted the shunt and continued voriconazole for 6 weeks. So basically, the important thing about this case is that you need to innovate in some cases because here you have a situation where you had to use multi-drug combination therapy and you had to use local antifungals also. And it's possible that other antifungals given by the intraventricular route may also work, but we didn't have data or precedent, and that's why we used caspofungin. And Dr. Soman was just telling me today that he's used all 3 of them, Mica, Enedula, and caspo for intravascular lock therapy. So sometimes if you have a precious line which you can't remove, like a port or a Hickman's line, then you may use lock therapy. So our institutional protocol for using Echinocandins is basically Enedula fungin we use if there is liver dysfunction is present or anticipated, or drug interactions are anticipated. Mica fungin we use if there's a urinary tract sepsis and true urinary tract sepsis due to Candida, not colonization, in neonates, and in hemopoietic stem cell transplant for prophylaxis, because Mica fungin is approved for that, either as 50 milligram once daily or 100 milligram thrice weekly. And in patients who don't have any of these factors, we may use caspo. And apart from that, we also have an antifungal stewardship program where we send BDG. And if Echinocandins are started empirically, then these are stopped if BDG is negative and there's no other evidence of fungal infection. But what I want to show the viewers is our increased use of Echinocandins since the COVID pandemic. And as Dr. Sasidharan was saying, that you do see a lot of fungal infections in these patients. And this is the number of antimicrobial days per 1,000 patient inpatient days. So if you look at the Echinocandins, this blue bar is 2018, where it was just 5. Then in 2019, it was also 6. But if you look in 2020, it suddenly shot up to 16. And that was because of the COVID pandemic and liberal use of Echinocandins in the COVID ICU. And then subsequently, you can see it in the month of, in the year 2021. And you can see that the use has been maximum in the months of May, April, June, because these were the peak times when we had our COVID ICU was full. So this is just to say that, while we are talking about the Echinocandins, but it is really important to practice good antimicrobial stewardship so that, we don't lose out on these important drugs. Thank you.
Thank you, ma'am. And I do not know, but whether I'm sure with the topic, this was planned by both the experts, the way Dr. Sasidharan had taken up the role of Echinocandins and how beautifully you have then talked in detail about which Echinocandin to choose in treating Candida infections in general and in various cases like urinary sepsis and other cases. And you've taken 3 beautiful cases up, and the last one actually we found very unique. We have some questions as well, which we will take up. Let me just had the questions and I had noted it down.
You can see them on the Q&A box.
Yeah, but I am not able to see, ma'am. Just I had noted it down. Just let me open them up. Yeah, ma'am. The first question is, madam, it is regarding, if you would see, madam, sorry, madam, for some reason, I am not able to see
So
the Q&A.
can I ask the questions then? Because I am able to see it. Can I
ask
them to
for some reason, I am not able to see.
Yeah. So I will ask Dr. Sasidharan, this question is for you, where Dr. Nasir is asking, how often do you think central line responsible for colony formation in your setup? How do you tackle?
So it's extremely bad to have fungus coming in from the central line in the first place, and we hadn't seen this till COVID came in actually. We did do a very large study where we looked at 374 lines that we pulled out from patients, and we actually looked for colonization, actual colonization. We just took it out and we did flame based agar cultures, and we found out that out of the entire 372, I think 372 lines that we took out, we found around 76 were them colonized, out of which only 6 were actually colonized with fungus. This is what we found in our study. It's there in public domain now, that particular study, but it's very rare to have colonization with fungus, and the places where you probably may get it, maybe the acute lymphoblastic leukemias, these places where there's neutropenic patients, there maybe you might get, but usually what is seen is not Candida. You normally get to see Fusarium and things like that. It's very rare though to have this kind of situation, and among those, if you get it, it's usually Candida parapsilosis that is normally seen if there is colonization from the central lines, is what we normally see. Is there anything different in your case, Dr.?
Yeah, I mean, we do see Candida colonization of central line, and that is probably because, again, I think it is related to infection control, because if your hand hygiene rates are poor, if your environmental, this is not good, then you can get Candida colonization, and Candida colonization of the CVC tip is difficult to ignore, unlike you ignore like Staph hemolyticus or Staph epidermidis, or even gram-negative bacteria, because if you have Candida colonization, then that is predictive of CLABSI, and you may actually have to treat these patients if they are septic. So it basically, you need to have good hand hygiene and good care of central lines if you want to prevent Candida colonization.
But there's something very important here. Out of the study that we did, something very interesting came up. What we found was that it really didn't depend on the Apache scores. Initially, I always felt that the more sicker the patient is, the more the chances of Candida colonization as an epiphenomenon is what I felt. But this is not what we really looked at. And in fact, then we looked into the literature and we found very similar results like ours, where it really doesn't depend on the severity of illness. We initially thought it was severity of illness in the relationship, but it's not severity of illness is what we feel. As you rightly said, it's more of infection control.
So there is another question. Is Echinocandin the right choice as empiric therapy in patients suspected with systemic fungal infection? Is it related to organs involved?
No. So if let's take it into 2 parts. Which are the organs that will cause the maximum of the problem and mortality? I mean, if you look at the evidence-based perspective, abdominal candidiasis is the worst of the lot. Abdominal candidiasis is something that kills very quickly. Mortality is very, very high as compared to any kind of candidiasis is what it looks like. And yes, if the patient is severely ill or on vasopressors or looks ill or clinically looks ill, the antifungal of choice is echinocandin and nothing but echinocandin, and that's been proved. Actually, if you actually ask from an evidence-based perspective, it's based on just one trial. But that one trial actually showed mortality. There are very few trials in literature that actually looks at mortality. And this was one trial that looked at azole versus echinocandin, which I actually showed in on my slides, which actually said that echinocandin is a drug of choice when it is when patients are critically ill. I don't think we can use any other drug in this place.
To answer that question, what would be your choice of empiric therapy? You'll have to look at the epidemiology in your ICU. And if in your ICU, more than 10 to 20% of your Candida are azole resistant, then you can't use azoles as empiric therapy, because then you will have to use Echinocandins, but you have to practice good stewardship, try and send BDG and try and de-escalate and try and stop if you rule out a fungal infection. There is a question probably directed to me that in our setup, Glebrata is rampant and we have used Caspo with not much success. So what is your view? I mean, I don't know whether these were patients who had, were truly having CLABSI with the Glebrata, then I think you should be able to, treat it with Caspo also, provided it is susceptible. And I think if you didn't have success, maybe you didn't do adequate source control, or there may have been other factors. But efficacy-wise, actually, I don't think there is anything different between the three Echinocandins. However, what we have seen is that if you have a patient, in the ICU, he has been in the ICU for a long time, and many of these patients need repeated courses of antifungal therapy. So what we have actually seen is that if you've used one Echinocandin and then later the patient has another episode of culture-proven sepsis, you might find that it has become resistant to that and you might have to switch to another one. So you'll have to look at that.
If I could just answer that question once more. See, there are a few studies. First of all, resistance to other classes of antifungal drugs, especially Echinocandins, is particularly concerning. I mean, it's really concerning that Echinocandin resistance is there. But notwithstanding, the Candida glabrata, it has got a very high level of resistance to Fluconazole, that is for certain. And this resistance has kind of remained constant for the last 20 years. It is not something that has changed since the last 20 years. The preferred treatment remains Echinocandin, but I've seen a couple of cases. I mean, I've done around 6 or 7 cases where we did find in vivo, the patient not improving, and we actually switched to amphotericin, liposomal, and flucytosine, and we've seen improvement on that. And then we actually went back to literature and we found that in the event that there is differential sensitivity, and usually the differential sensitivity is to Caspo. Is what we normally see. So if that is there, then you may either try another Echinocandin or you might switch to the combination therapy, is what it looks
like. Since most critically ill patients are on various drugs, can we say that it is advisable to use Anidula empirically, keep drug interaction in mind? Well, if you look at the drugs which are in the list of interactions, many of the critical care patients are not on these because, nevirapine is not commonly used. Rifampicin, many of them are not on. And even if you look at the anticonvulsants, most of the critically ill patients nowadays are on levetiracetam because, that has least interactions and more predictable. So that list of drugs is not there. So therefore, you can't, choose Anidula for that reason. And however, if you have an immunocompromised patient, like you have a patient like post-hematopoietic stem cell transplant or post-kidney transplant or post-liver transplant, where you know that these patients will be on drugs like cyclosporin or tacrolimus, then you obviously have to avoid Caspo. That is for sure. There's a question that says that since Caspo is now available at a much lower cost, does it make sense to consider Caspo first? So I think I made that point very clear that the choice of Echinocandin, apart from the situation, is also dependent on the cost and the availability. So if your patient, you need to use an Echinocandin and you don't have those specific things like severe liver dysfunction, drug interactions, urosepsis, etc., and your isolates in your ICU are showing susceptibility to Caspo, you can use that. because efficacy wise, I think they are all the same. And also another thing is, I don't know, but we try and use all the echinocandins because we find that use of one, you have this differential sensitivity. So it's always a good idea to actually use all the echinocandins, because if you make a policy in your ICU that I will use only just one echinocandin, then you might be losing out on that. So I don't know what Dr. Sanjeev has to say, but we use all the echinocandins in our ICU depending on the situation.
Yeah, so yes, absolutely. So we actually use everything. We use it's just a matter of a week of one particular, then another week. It's like cycling that we've been doing. We've been doing that, and especially so when we have got Candida rugosa for some reason. We got a couple of Candida rugosa which are exceptionally sensitive, resistant to Anidula fungin and sensitive to Mica fungin. For some reason, I don't know. In my hospital, when we do sensitivities, Mica fungin seems to be more sensitive in many of these Candida fammatas and rugosas.
Yeah, so it also depends on what is the sensitivity in your ICU. And another question is, will initial empiric therapy with fluconazole also increase chances of resistance to echinocandins? No, I don't think so. Because it will probably cause colonization with, azole-resistant Candida. And it's not, I know where this is coming from. So, for example, if you use vancomycin, you might even be driving daptomycin resistance. There is that phenomena. But I don't think there is any data to say that use of fluconazole will increase resistance to echinocandins. I think those are the questions.
Thank you very much, ma'am, for taking this up. For some reason, I'm not able to see. Suddenly, all the questions have vanished, but I could see that these questions were there. Thank you for taking this up.
And there is another question last I just saw, which echinocandin is effective or drug of choice to treat Candida biofilms. So again, there is some data to show that Anidula fungin MICs are the lowest in biofilms. And but there is no kind of trial data to suggest that one is better than the other.
Right. Thank you very much, ma'am. And I'm sure that we have enjoyed your presentations, and it was a great learning session, but you would have enjoyed the questions and you would have understood how intently our audience have been following your presentations as well. And I'm sure, madam, first of all, I would like to thank the audience for their enthusiastic participation, and both the speakers, Dr. Sanjith as well as Dr. Tannu Singhal, for sparing time and enlightening us, and we look forward to seeing you in many more of our sessions going forward. Thank you very much, and thank you to all of you.
Thank you.
Thank you very much.
Thank you, Dr. Sanjeev.
Thank you, Dr. Tannu. Bye-bye. Bye-bye.
Bye.